Good evening to everyone and welcome to today's session. Today we are slightly late. We have many things to cover today because latest by Friday evening we are supposed to finish ophthalmology. So in this endeavor we have finished glaucoma, cataract, what else? I forgot what we finished. Nearly around the first 26 topics we have finished and there are some small kutti topics in the end which we will take up. Can you increase the voice? Please let me know how is the voice. Is it clear? Online classmates. So we welcome our online friends Amrita, Kunal, Murali, Shahila, Neena, Karnool. I am very happy today Karnool students are online. Tirupati, Vizag, etc. Central serous retinopathy is a very important topic. What is this? In the retina, there are 10 layers. In that, the neurosensory retina spontaneously gets detached, especially in the macular area, to the central part of the retina. Is the whole problem of central serous retinopathy. It may or may not be attached with retinal detachment. Now, the males between 20 to 40 are the common age group who are affected with the central serous retinopathy. And what is the underlying cause? Why should serous fluid should accumulate and make the neurosensory retina to get detached from the other layers? That too in the macular area. It is a hyperpermeability. You know, who is there behind retina? Choroid. Choroid, outside choroid you have sclera. They are all wrapped within one another. Any choroidal hyperpermeability will lead to the breach in the outer blood retinal barrier, and that lead to development of the seepage of the fluid between the choroid and the retina and lead to the development of central serous retinopathy is what needs to be remembered. So this is a typical subretinal fluid with pigmentary changes in the macular area, which is classical of central serous retinopathy. Then are there any provocating factors? Yes sir. Emotional stress, hypertension, any systemic steroids. This is one of the favorite MCQs in the entrance. Can steroids by themselves can predispose to the development of the vision loss? Yes. Systemic steroids can be one of the precipitating factors for the increased permeability of the choroid, leading to the serous effusion underneath the macular area, leading to central serous retinopathy, leading to the development of the blindness, is what needs to be remembered. So there is a sudden onset of the painless loss of vision with positive scotoma, micropsia, and metamorphosia. So these are all the important features in case of central serous retinopathy. Suddenly all the buildings will be looking changed in their shape. Metamorphosia. Gulliver and Lilliput. Small things look big, big things look small, etc., etc. Is all the problem if there is any fluid underneath the neurosensory retinal epithelium is what need to be remembered. So today we also have the Kadapa students. I hope the internet problem there is solved. So this session is broadcasted into a classroom in the RIMS, Kadapa. I am very happy. Now, if you do fluorescein angiography, you can be able to appreciate that macular area may subretinal fluid in the form of central serous retinopathy. So in the macular area, there is a small elevation which leads to circular ring-like reflex. Normally, whatever the foveal reflex you get, that become absent or distorted. Where is fovea located? Fovea centralis. So the place where there is the highest visual acuity in the macular area. Normally it gives a reflex, but because of this subretinal fluid, that foveal reflex will be distorted or become absent is another important feature. But good news is, unlike retinal detachment, central serous retinopathy is self-limiting in nature, but it is often recurrent. Resolution will take about 3 weeks to 1 year, and after the resolution there may be few atrophic changes, or it can leave a little bit of pigmentation in the retina. My voice is really very bad. Every summer I suffer a couple of weeks a curse of hoarseness of voice. Earlier I was worried about vocal nodules, blah blah blah. But later on I discovered the vocal cords are, whenever there is any upper respiratory infection, vocal cord edema. So just bear with this not my natural voice. I am speaking on a dysphonia plica ventricularis with the false vocal cords. Now, if you do a fluorescein angiography, there are certain classical features of central serous retinopathy which are the favorite MCQs of the examiner. One is called ink blot pattern, a small hyperfluorescent spot which gradually increases in size, called as ink blot pattern. Smoke stack pattern, where a small hyperfluorescent spot will ascend vertically like a stack of smoke, is another important feature, and it gradually spreads and ultimately settles as a mushroom configuration. So this central serous retinopathy on fluorescent typically looks like this, like a ink blot. It takes about 3 weeks to 1 year to resolve. This is another example where you can see that focal hyperfluorescence in case of central serous retinopathy, and you can see the leakage of the fluorescent dye with the neurosensory detachment, and this is another example of that smoke stack like rise of the fluorescent settling down in a mushroom pattern is another important feature. And this is a 47-year-old man with central serous retinopathy, typically once more showing the presence of the leakage of the dye. So ultimately you need to remember it is the choroidal hyperpermeability which is the underlying mechanism is the whole story. So how do you treat? Since it is self-limiting, you take your consultation fee as an ophthalmologist and reassure the patient, don't worry, nothing will happen. 90% of cases there is a resolution. It takes about 4 to 12 weeks for the resolution to occur. Is there any indication for photocoagulation? Ophthalmologist has a gun for everything. He can apply burns to the retina wherever he wants if he doesn't know what to do. So that's how we treat, no? Lot of entities, neovascularization in retina, etc., etc. So the same photocoagulation you can use here, but what are the important indications? Any long-standing case more than 4 months with central serous retinopathy. Recurrent central serous retinopathy with visual loss. Since it is occurring in the central part of the retina, visual loss is a very major problem. And any permanent loss of vision in the other eye, they are all the important indications. So that's all the story, doctor. Central serous retinopathy remains with you. Cystoid macular edema is the next important retinal entity on which lot of questions are asked in the entrance. So when I have reviewed these are also the topics important for the MBBS exam, after analyzing past 20 years of UHS, University of Health Sciences papers, to my surprise, hardly 1 or 2 times they are asked. That means we passed without knowing any of these things in ophthalmology, just by reading cataract glaucoma. At most uveitis. So, cystoid macular edema. What is the problem in this? There is a fluid once more in this also. There is it in the outer plexiform and the inner nuclear layer of retina are there, no? The 10 layers of retina. Between these 2 layers, if there is any fluid, then you call it as cystoid macular edema, and this edema is typically around the fovea. Inside the fovea, you have a fovea, a vascular area. Now, what are the common causes? Very important. There are some predisposing causes which are also ophthalmic conditions which can be predisposing. If you have done surgery for cataract, post-operative cataract extraction, or if you have done a corneal transplantation, penetrating keratoplasty, retina can become angry. It is like a principal sitting in the retina. How come without my permission my cornea is disturbed and my cataract is extracted? Since I am angry, I will release fluid between the 2 layers. So any of these surgeries can be a precipitating factor. Then any diabetic retinopathy or a central retinal vein occlusion can also predispose to the development of cystoid macular edema. Any intraocular inflammation. We have discussed, no? Ciliary body is having 2 components. What are they? A folded part called pars plicata and a plain one which is more peripheral, which is called pars plana. Any inflammation of pars plana. Basically, pars plana is part of ciliary body. It merges with choroid. Retina also starts at oris aerata. Anteriorly boundary is oris aerata. So, any inflammation of the pars plana can lead to the seepage of the fluid between the layers of the retina. So, pars planitis, posterior uveitis. Suppose if there is an underlying choroiditis, it can lead to cystoid macular edema. Or any Bessett's disease like vasculitis also can lead to the development of the cystoid macular edema. Then very important MCQ in the exam. Are there any topical drugs? If you put it into the eye of the patient, it can lead to development of cystoid macular edema as a side effect. Adrenaline eye drops, especially if you are using to decrease the intraocular pressure. What is the, yesterday we studied, no? Anti-glaucoma drugs. So, adrenaline eye drops are one of the types of the anti-glaucoma drugs. They will decrease the uveal, what is that? Aqueous humor production. But if you use it in a person who had a cataract extraction, a phakic eye, then such persons will develop cystoid macular edema. Then retinitis pigmentosa, yesterday we studied bony spicule appearance, you remember, no? Retinal dystrophies. There can be development of cystoid macular edema. Because it is a degenerative state, retinitis pigmentosa fundamentally. So there is a leakage of the fluid because of breakdown of the inner blood retinal barrier. So mainly where is the fluid coming in the cystoid macular edema? It is the retinal capillaries which are oozing out. Between which layer and which layer, doctor? Outer plexiform and the inner nuclear layer of the retina. Remembering that it is the fluid between these 2 layers is all about knowing what is cystoid macular edema. See, there are 3 things. Retinal detachment. From where it is detaching, it is not detaching from anybody. Actually, it is a misnomer. Detachment is a misnomer. Right? So, in which plane retinal detachment is occurring? In which plane central serous retinopathy is occurring? In which plane cystoid macular edema is occurring? These planes are very important to be remembered, is what I like to tell you. So, if you do fluorescein, What is the classical pattern? My favorite MCQ of the examiner. It is a flower petal-like pattern. Flower petal-like pattern. Maybe ophthalmologist discovered it on the wedding day. So there is no time to go home and share the time. So flower petal-like appearance should be remembered. A long-standing edema between these two layers can lead to development of a hole in the retina. Lamellar macular hole can develop because of a long-standing cystoid macular edema. So how do you treat, doctor? Generally, there is an underlying predisposing condition leading to the cystoid macular edema. Suppose if it is diabetes, then treatment is gun pakdo, coagulate karo, photocoagulation. Then if it is adrenaline, stop using it. And are there any drugs, if you instill it into the eye before an intraocular surgery, you can decrease the chance of developing cystoid macular edema? Yes, sir. Indomethacin, flurbiprofen, the topical anti-prostaglandin drops, if you use them before intraocular surgery, the chance of cystoid macular edema decreases. Epinephrine will increase. So this is a very important MCQ to be remembered. You can also give oral acetazolamide is another option which is available. So that's all the story of cystoid macular edema. Mainly, what are the challenges in this? In which plane is the separation occurring? Predisposing factors, association with epinephrine. So these are the few 3-4 points you remember. That is too much expectation on an undergraduate in ophthalmology. Now, age-related macular degeneration. What is the common question asked by the examiner? If you are in India, cataract is responsible for the blindness in developing countries in elderly people. If you are in America, then what is the most common cause in developed countries in elderly people? Loss of vision, age-related macular degeneration. It typically occurs in the people who are above 59 years, and it is of two types. Non-exudative type, exudative. Whenever there are two types, examiner love to know which is most common type. So you must be quite sure. Now what are the risk factors? Heredity. My grandpa had age-related macular degeneration, my pa had, I am having, my son will have. Smoking, hypertension, exposure to sunlight. That's the reason in Caucasians, it's much more prevalent than the people who live in Antarctica. Antarctica, will they have more or less? Poles versus equator. Now, what are the different clinical types? Non-exudative, otherwise called atrophic age-related macular degeneration. It is also called dry or a geographic age-related macular degeneration. 90% of cases are non-exudative, hence called dry. There is a gradual loss of vision, unlike exudative type where it is much more faster. We have, why this is important? One of the short answer question in the exam is sudden loss of vision. Painful, painless. You must know it used to be a favorite question in university, no? That is also favorite question for entrance also. So patients will have a distorted vision, difficulty in reading because of a central shadowing due to the macular degeneration. Now what is the ophthalmoscopic hallmark of age-related macular degeneration? Drusen. Drusen is also called colloid body. So what is a drusen? A small, discrete, yellowish white, slightly elevated spot when you do the fundoscopy examination is the hallmark of the age-related macular degeneration. The retinal pigment epithelium in the macular area will show atrophy. Pigmentation which is clustered is very important. And why it is called geographic variety of age-related macular degeneration? Because when you look through fundus, there will be enlarged atrophic areas within which the larger choroidal vessels will be seen, and that typically gives that geographic atrophic appearance is what need to be remembered. Then what is the lesser variety? Exudative type is lesser variety. It is much more rapidly progressive in nature with a marked loss of vision, and there are various stages through which this exudative variety passes. First there is a drusen, then the retinal pigment epithelium will detach, then choroid develops neovascularization, then hemorrhagic detachment will be there of retinal pigment epithelium, then neurosensory retina will undergo hemorrhagic detachment. Ultimately there is a scarring which will be developed in the macular area. These are the various stages through which the exudative type will be progressing. Then there is one more classification called early and late variety of age-related macular degeneration. What is early? Early means what findings are early, what are late. Presence of drusen and any retinal pigment epithelium hyper or hypopigmentation is called as early. Whereas the geographic atrophy or the development of any neovascularization or presence of any disciform scars in the macular area, they are all called late stages. Now doctor, what is the treatment of this entity? As much Indian ophthalmologist has to worry on cataract, Californian ophthalmologists need to worry about age-related macular degeneration. There is some role, not a very proven role, for antioxidants. Vitamin C, vitamin E, beta carotene, zinc, copper, they are known to have some role. If it is a exudative type, where there are neovascularization features, then there is a role for argon green laser photocoagulation is what need to be remembered. So argon green laser photocoagulation is the treatment of choice if there is any choroidal neovascular membrane in the extrafoveal location, then that is the treatment of choice. See, it is a macular degeneration. Macula mein you are having lot of things, fovea, parafoveal area. There are subclasses based on the location where the degeneration is there. So if it is foveal, extrafoveal, choroidal neovascular membrane, if it is there, then argon green laser photocoagulation is the treatment of choice. Subfoveal, juxtafoveal, if it is that choroidal neovascular membrane, then photodynamic therapy is the treatment of choice. So what is meant by photodynamic therapy? Too much imagination, right? So very simple. We use what is called vertiporphin. It is a photosensitizer. It is basically injected intravenously, and the area where the choroidal neovascular membrane is there, it is then exposed to a diode laser. First you put photosensitizer, then that will be taken up by the neovascularization area, and then you will apply diode laser, and that in turn will lead to the disruption of the cellular structures and the occlusion of that neovascular membrane, and it won't damage other areas, photoreceptors, capillaries, retinal pigment epithelium, and all those areas are there. No, we don't want to disturb them. We only want to go and like the American Scud missiles bombing on Afghanistan. You want to particularly only act on one particular area which is degenerated. So that is the reason that area will pick up this photosensitizer, because it is a vascularized area. On that you use this argon diode laser and you will destroy it. So that's what you typically do in photodynamic therapy. Just you need to know Om Namaha Shivaya. Main headings, 1-2 points about them. parafoveal area, juxtafoveal area, what are the differences, which is the treatment of choice, rarely examiner can ask. What is commonly asked by examiner, that the smokestack pattern, flower petal pattern, predisposing factors, everything I labeled in the notes given to you, what is asked as MCQ. But let us also know 2-3 points. Yahan tak aa gaya na, wo bhi khatam karenge. So you have a transpupillary thermotherapy, which is also done through diode laser if there is a subfoveal neovascular membrane. Then you can also do a submacular surgery. Then you can give anti-angiogenic agents. Interferon alpha can do that work, and also you can give a vascular endothelial growth factor inhibitor. Any of them can be given. Ultimately the idea is make the choroidal neovascular membrane in the macular area, which is predisposing to all this degeneration in the senile population, to get destroyed. So that is the whole idea. Okay, doc? So this is all the story about 3 important entities you understood. What are they? Central serous retinopathy, cystoid macular edema, and the age-related macular degeneration, which you have exudative and non-exudative type, is what need to be basically remembered.